Next session will be on diplopia. Here we will try to talk about non-neurological causes of diplopia. This talk will be under 4 headings. First, I will try to talk about the refractive causes for diplopia. Then, Dr. Samyukta will be talking about comitant strabismus, and followed by Dr. Chaitanya, who will be talking about orbital causes, and finally Dr. Divya Kishan will be talking about binocular causes for diplopia. So, coming to the first talk, diplopia due to refractive anomalies. So, the refractive aberrations which causes diplopia can be talked under 2 headings. One is refractive errors and other one is media abnormalities. So, we will try to talk about a small case. This is a 60-year-old male patient who had done his cataract surgery 1 week prior, and he came with complaints of diplopia. So, a patient with diplopia, like in any other case, we take a good history. We try to know the onset of the diplopia, duration, any associated symptoms. So, one important thing is we need to know is if it's a binocular diplopia or a monocular diplopia. So, we ask the patient, sometimes the patient will tell us when he or she closes one eye or either eye, the diplopia resolves. So, this patient said he is having diplopia monocularly, and we can confirm it by doing a cover test. We cover either eye and see if the diplopia resolves. So, the monocular diplopia mechanisms can be dealt under 3 headings. First, light diffraction, then metamorphopsia, and cerebral polyopia, which can cause bilateral monocular diplopia. So, what is light diffraction? It's a property of the light rays to bend around the corners of an obstacle. So, here as you can see, the light rays met with an obstacle and it bends around that obstacle. So, this property is called light diffraction. So, what happens is that when there is an opacity or aberration in the optical system, the image of an object can fall on the fovea and the extra foveal retina of the same eye, and this can lead to diplopia. So, what does a pinhole do? A pinhole will cut that diffraction, and only the foveal image will fall on the retina, and the diplopia will resolve in such cases. The second mechanism of monocular diplopia is metamorphopsia. As you can see, some retinal pathology like ERM can cause distortion of the retinal images, and here it does not resolve with the pinhole. Cerebral polyopia is a different topic and we will skip that. So, coming to our case, the patient complains of monocular diplopia. So, the next thing we can do is do a pinhole test, and in this case the diplopia resolved with a pinhole. So, the cause mechanism may be a light diffraction. So, the light diffraction, 2 causes are refractive errors or an ocular media abnormality. So, we did a manifest refraction for the patient, and patient had mixed astigmatism with 1.5 diopter cylinder and 2.5 diopter cylinder at 110, and the patient vision was 618. So, next we have to do a slit lamp examination to look for any ocular media abnormalities, and the slit lamp examination is within normal limits. We have to do a objective refraction, retinoscopy refraction, which showed higher astigmatism with minus 3.5 diopter sphere with the 6 diopter cylinder, and the patient vision improved to 6.9 from 6.18, and the diplopia gets resolved. So, this is a case of high refractive error, high astigmatism which caused a monocular diplopia. So the tight suture may be causing the problem, and the suture removal will reduce the diplopia. So the refractive errors which can cause diplopia can be a high ametropia or irregular astigmatism, as in this case. Anisometropia can cause anisoconia in cases and even cause binocular diplopia. So the take-home message in this case is objective refraction is mandatory for during the evaluation of binocular diplopia, because subjective refraction can be unreliable, especially when the vision is poor. The next thing is about the media abnormalities. Any abnormalities from the anterior to posterior can cause light diffraction and monocular diplopia. So it can be a lid tumor which compresses the cornea, or a tear film abnormality, or any corneal opacity or irregularity. It can be multiple pupil like polychoria, and it can be an abnormality in the lens which cause diplopia. This is another case, a 25-year-old male presenting with the diplopia, headache and dizziness. And from the symptoms and from the evaluation, patient is having monocular diplopia. His vision was 6.9 in the right eye and 6.6 in the left eye. So we have to do a pinhole test, and the pinhole test, the symptoms resolved. So we have to do a slit lamp examination, and slit lamp examination showed a lens opacity in the central visual axis, the well-defined circular opacity, and the rest of the examination were within normal limits. So this was a case of lens causing diplopia, and a phacoemulsification surgery resolved the patient's symptoms. So like in the last case, a cataract can cause monocular diplopia. Post-surgery, a subluxated lens or descended lens can be another cause. Even a vitreous opacity like an intraocular foreign body can cause light diffraction and thus diplopia. So to summarize, the diplopia, one main thing is we have to see is monocular or binocular diplopia. So if it's a monocular, it can be even bilateral like in cerebral polyopia, or usually unilateral. If it's a unilateral monocular diplopia, the next thing we have to know is if it's due to a light diffraction mechanism or metamorphopsia. So we have to do a pinhole test, and if the diplopia persists with the pinhole, we have to look fundus for any maculopathy. We also have to do a good objective refraction in such cases, and slit lamp examination to look for any media abnormalities. This is another important instrument which will help us during this assessment, as in we can get an idea about the astigmatism or any refractive errors by seeing the red reflex. We can even know identify the media abnormalities like keratoconus in this patient, and we can know if the opacity is in front of the pupillary plane by looking at the movement of the reflex. Like if it moves along with the eye movement, the opacity is in front of the pupillary plane, and if it's behind the pupillary plane, the opacity will move against the eye movement, and it will be stationary in case of if the opacity is in the pupillary plane. So to summarize, a case of diplopia, we have to do take a good history, do the cover test, and if it's a monocular diplopia, monocular diplopia, we have to see if it's a unilateral, and then we can do a pinhole test and see if the diplopia resolves. And if it persists, we have to look for any metamorphopsia like a fundus for maculopathy. And if the pinhole, if the diplopia resolves, we have to look for any refractive aberrations, and we do have to do a good slit lamp examination, refraction, and direct ophthalmoscopy. These are for the further reading. Thank you.
Thank you, Naveen, for that very